fact, the usual test kits we use in the field when we use cartridges do not work for this particular strain, and therefore all the laboratory testing has to be done using PCR platform. In this way, it means that we are engaging much more at the established laboratories, and 254 new cases, including 136 confirmed and 188 suspected, and 6 new deaths week. This gives us a case fatality rate of 2.4%. And the new cases were reported from the DRC, Egypt, Nigeria, and Sudan. This reflects a 54% decrease in the number of new cases compared to what we reported in the previous brief. And for the 4 countries, DRC has reported 9 new confirmed cases, 118 new suspected cases, and 5 new deaths, for a case fatality rate of 2.2%. Egypt has reported 1 new confirmed case, no deaths. Nigeria has reported 123 confirmed cases, no deaths. And Sudan has reported 3 confirmed cases and 1 new death. So the concern here is that although the numbers are decreasing, the number is aware on 77 suspected cases with 143 deaths, giving us a case fatality rate cumulatively for this year of 2.6%, reported from 12 of the African Union member states. We continue to provide training, particularly in laboratory diagnosis, so that we can confirm as many of the cases as possible using real-time PCR platform. And the latest where we've trained quite a number of scientists from different countries, and we'll continue to do this. We are also making available test kits and supporting the risk communication and community engagement efforts from the countries that are affected. Third is Rift Valley fever in Mauritania. Since the last briefing, we have documented 14 new confirmed cases and 22 suspected cases and 6 new deaths. This gives us a case fatality percent in Mauritania, and this is a 50% increase of deaths compared to the last brief, and this is a concern. Cumulatively, we are seeing 24 confirmed cases, 78 suspected, 12 deaths, giving a case fatality rate of 11% from 5 regions of that particular country. The Ministry of Health there has enhanced surveillance to limit spread, and Africa CDC's emergency teams are actually monitoring very closely the situation there and providing remote support to the government of Mauritania. Also in Mauritania, we have documented the Crimean Congo hemorrhagic fever. And since the last brief, 1 new confirmed case and 15 suspected. No deaths have been reported. This is a 50% decrease in numbers of new cases as compared to the last briefing. Cumulatively, 2 confirmed cases, 49 suspected cases, no deaths, and again, like the government of Mauritania in monitor affected areas to ensure that the 111 giving us a case fatality rate of 2.3%. And these are from 2 countries, that is Cameroon and Malawi. Cameroon reported 63 new confirmed cases and 640 suspected cases, with 15 deaths for a case fatality rate of 2.1%, while Malawi has reported 448 new confirmed cases with 12 deaths for a case fatality rate of 2.6%. Cumulatively, over this year, we have documented 42,389 cases with 648 deaths for a case fatality rate of 1.5%, and all these reported from 14 of our member states. And we continue to support particularly the community engagement, are aware that there is cholera and how it affects. Finally, as I speak, I am in Lusaka in Zambia, where today, in the presence of Her Honor, the Vice President of Zambia, we have just launched, part of the reason why we're having challenges, we have just launched the Continental framework for mortality surveillance, because during this pandemic, we noted that the numbers were not accurate, and this means that the mortality surveillance system within countries was not functioning optimally, and therefore we have launched a framework today that is going to support countries to establish their own national level mortality surveillance systems. That way we can have better information, more complete data for deaths and why, the reason for those deaths. And this is going to help in ensuring that we are tracking the right things across the continent. Wayne, back to you.
Thank you very much, Ahmed, for that. I'm sure we're all glad to note the progress in terms of the systems as well as the operations of the Africa CDC. It is now time for me to open up the floor for questions from journalists who are joining us online. Before we do that, let me just advise that we can take your questions on WhatsApp, as well as live, and also on the Q&A section. So we've had Gabrielle Steinhauser, who's been on hold for quite a while. Gabrielle, it's nice to have you back. We've kind of missed you on the program, so welcome back. Please go ahead with your question.
Thanks. I'm catching up though, so I have a few questions. So a year ago at the UN General Assembly, a goal to vaccinate 70% of the global population against COVID-19 by the end of September 2022. Especially Africa is far off that target. And I would like to get your assessment of why that is. Then given, that a lot of governments, especially on the continent here, are kind of operating in an environment of resource scarcity, and given that, the impact of the virus seems to have receded, do you think at this point it's the best use of African governments' resources to focus on COVID vaccination, or are there other more pressing health concerns that maybe need to be prioritized? And then finally, you mentioned the number of J&J doses that have been delivered, which is also far off the number that were ordered. So I'm wondering, what's happening here? Do governments still have to pay for the doses that they ordered, even if they're not using them, because there's plenty of free doses now available from COVAX, or what's the situation here?